Found the rest. That's fine. All right, let's get back. Alrighty. Alright, back at it. So these are the primary goals of conservative treatment for idiopathic scoliosis. The first one is to stop curve progression, basically at the time of puberty, or reduce it. There's not great research showing the ability to reduce scoliotic curves. We'll go into that a little more. There's really good research that shows that bracing is very effective at preventing progression to the surgical range. Okay, so it may still progress, but at a slowed rate. There's not good research at all showing that braces can help improve the curve once the curve has already started progressing. And then likewise, with scoliosis-specific exercise, they have found that there is a mild degree of relation between the performance of the exercise and, again, the slowing of the curvature. The biggest goal, though, is to stop the progression to the surgical range. So I say that because it's very irresponsible to promise or tell people oh yeah, we're going to fix your curve. That's not. You can restore their function, improve their pain, improve their mobility, do everything associated with it, and sometimes their curve might actually improve. But that should not be your goal, and it's worthwhile telling that it's very important, having that conversation with the patient right away, talking about the things that you can improve and that will get better, versus giving them these unrealistic expectations, because you will wind up in a situation where everything is better, mobility is great, strength is great, they feel good, then they go see their spine center doc who spends 3 minutes with them and is like, oh, curve progressed 3 degrees, and then they leave the room, and then they come back to therapy a mess because they're like, it progressed. But again, if they're prepared for that, it's a much better conversation to have.
So research says that there is good results with stopping the progression. So I can tell a patient there's a good chance that the progression will stop.
I typically say there's very good research indicating that it will slow the progression of your conditions. So doing this will have a significant impact versus not doing it. That's usually the verbiage I use.
But the whole goal is we need to keep you out of the operating room.
Yeah, but I'll also say, I'll be very honest. I'll say, our goal is obviously, you can say, our goal is obviously that we want to reduce the curve as much as possible. Just don't say, we will reduce your curve.
Yeah, but there's no way to measure, if we did nothing versus doing stuff. There's no way I can say, oh, well, we're going to make sure that it doesn't decrease.
Yeah, there is a lot of research that does show that the combination of bracing and scoliosis-specific exercise does a really good job of halting or stopping the curve progression.
How would you prove that, though? Do you have a control group of people who didn't have any intervention?
Yeah, that's how they did. That's not how I do it. that's how they did it. So there are a lot of control groups that looked at it over time using bracing versus not, and there's a lot of issues with both. And you're going to see that the evidence behind all of this is not great. So this is it's not as straightforward as it seems, but we'll get into that a little more. The second biggest goal of comprehensive conservative management is to prevent or treat respiratory dysfunction. So we talked about the significant changes that occurs from the rib standpoint, and you will actually see some changes in respiratory function in individuals who typically have more moderate to severe curves. And part of my evaluation process that I'm going to go through usually involves taking a look at expansion, chest, diaphragm, and comparing from there. But this is something that absolutely can happen, and if you do see individuals with moderate to severe, it's one of the first things, day one, that you should be addressing. To prevent and treat spinal pain. So this is a little tough because there is some conflicting research about this. They have found that in adults who have been previously diagnosed with scoliosis, some studies said that there was a 3 times higher rate of chronic pain complaints compared to individuals who do not have scoliosis. And then there's one of the studies indicated that there was a 20 times increase in short, transient, sharp darting pains. So pains that you're just oh, it feels like a sticker and then goes away. in individuals with scoliosis versus who do not have scoliosis. So again, part of this is just like we do with everybody. We want to try to prevent or treat any of this pain that comes associated with it, and it's not much different than treating our other individuals who might have more chronic pain, but keeping in mind the structural differences and how that impacts some of your options available to you.
So it's a common complaint of someone with scoliosis, that sharp darting pain.
Mm-hmm.
And someone says, I have that sharp darting pain. What is that? What is your response?
I usually give them the same hesitant response as when I describe normal pain to them, to be honest. I don't say, like, it's a result of your vertebrae compressing on each other. It's a result. I usually give the same kind of spiel that I gave during my chronic pain talk, where pain is complicated because of changes in your spine. It's normal for you to experience, different aspects of pain, but that's something that we're going to work on through some of these exercises. And it's important for you to know that that pain is not associated with a worsening or progression of your condition. That's the biggest thing. Like, people will feel like really great for a long period of time, then they might get these like sharp pains. Again, they're usually like pretty quick, but then it's like a reminder for them that they have the condition. But it's important that they know that it is not a sign of progression or worsening. It is just a normal association with what they're feeling, and our goal is to try to minimize that.
For the respiratory function, are you measuring that in any way, or is this
We do, yes. So I'm going to get into a little bit. I'll jump ahead a little bit. You can use a tape measure to actually look at expansion through the chest versus the diaphragm, and you will see a lot of the paroxysmal breathing patterns in individuals. The other unique thing you'll see with Scoli is you'll actually see a lot of unilateral expansion, and the other side's not going at all. And the basis of like corrective posture is actually utilizing that breath to fill in the space so that you're getting a 360 brace effectively. So a lot of times you will be able to just visually see it, but it's actually nice to sometimes show a patient, like grab a tape measure, wrap it around their chest, and just be like, just breathe. And you'll see it go. Then you'll put it around there, like right where their diaphragm sits. You tell them to breathe again, and nothing changes. And then explain, like, this is what we're going to be working on. We're going to be working on balanced breathing, utilizing your diaphragm. And I'll use that as a tool. So it's like, I want you to get from, I'm making this up. I can't even think of what the number would be. I want you to get from 29 to 32 or something like that. And then that's what they'll work on. In some programs, if there is a respiratory involvement, they will use spirometers and things like that. In my setting, in our setting, like, I shouldn't say you won't. I personally haven't had that to use that. But there are certainly individuals who treat more moderate to severe cases who do use spirometers as exercises over time and evaluative tools. And then the last one is this is I'm not making fun of it at all, because it's a very important thing for a lot of people. But a lot of the European research does focus on the aesthetic with scoliosis. So a lot of the outcome measures and things that are recommended by these European organizations actually put a very high emphasis on like aesthetics. But again, not in a bad way. It's about self-appearance, confidence, things like that. And that actually is one of the primary goals. So to improve aesthetics via postural correction, but it should be more accurately like the self-confidence associated with it, because people
feel good.
Yeah, exactly. No, I mean, it's a very, it's a for some people, if they feel embarrassed by it, they feel so. It's a huge thing that we don't gloss over, but it's one of the few conditions where I feel like there's such heavy research looking into that piece, which is kind of cool. But okay, this slide's going to mean absolutely nothing to you right now. This is the most important slide that I'm going to give you guys. We're going to go through what all these individual things mean, then we're going to revisit this slide and talk about why this is so important, okay? But this is the slide that you should be using for treatment recommendations. I will be sending this to you for individuals with scoliosis. On the left, you will see the age of diagnosis of the individual. The next column, you will see the Risser level, if they're adolescents, or you will see pain or no pain in older populations. Then you will see the degree of the Cobb angle, so low, moderate, or severe. I put it up here. Low is 10 to 20, moderate is 21 to 40 in this scale, and severe is 41 plus. And then you'll have the minimum recommendation for each individual in that classification and the max recommendation. Okay? We're going to go through what each of these mean, then we're going to revisit this slide so it makes sense. So in there again, and and these are the SOSORT, the International Scoliosis Society's like slides. If you see NO, it means nothing, no treatment is needed. This is just observation. This happens a lot with your more mild cases of scoliosis or your adult onset scoliosis with no pain. Like, you're not going to treat somebody for something that's not there. If they have no issues, you're not going to do it. Observation is the first step of an active approach. So you'll see a lot of kids who get scoliosis and they'll be just placed on observation. This can range from every 2 months to every 5 years, depending on the curve progression. A lot of times it does include taking scoliosis survey radiographs, which is a specific series of radiographs that they use to determine the progression, but not always. Just like when we talk about like MRIs with back pain, like we don't want to overutilize imaging for things that aren't necessarily problematic or challenging. But I will say with a lot of the spine centers I work with, at least, they usually do repeat radiographs at these like observation sessions. If you see PSSE, this is a super fancy European term, physiotherapeutic scoliosis specific exercise. That's us. That's what we do. And this includes primarily outpatient physical therapy, not inpatient. And the frequency varies depending on the individual and studies that you look at. Usually, this is pretty wild. They go 2 to 7 days a week, depending on the complexity of techniques. Through the courses that I've taken and through the research that I've reviewed, Europeans have a much higher recommendation for in-person care for conditions like this. Whereas, like, I personally will see somebody maybe once a week, sometimes twice a week for something like this and give them a lot to work on their own. But the recommendations are typically pretty high for frequency. And I think it's because they really focus on the nitty-gritty of how their posture looks. And it's something that they don't feel like they're able to just feel or see on their own, which makes sense. But if you see SIR, Special Inpatient Rehab, I've never seen this in the States, to be honest. They do have programs at specialized health centers where they'll do basically inpatient treatment for scoliosis. Doesn't mean they don't do it. I just haven't seen it myself. I've never had a patient undergo this. But this is a recommendation for certain subpopulations. Bracing. So for bracing, there's different types of bracing for individuals with scoliosis. You are typically going to wear a brace if it's prescribed until you are skeletally mature, so until you're hitting that Risser level of 4 or 5. And then the main goal, again, is to halt scoliosis curve from the time of progression. And if someone is recommended like a rigid brace, you do still get out of it for exercise. So the different types of recommendations that you will see are nighttime rigid bracing. That means they only wear the brace when they're typically in bed, or like the time periods before and after. So like maybe like prepping for bed, maybe prepping for the day, and that's usually 8 to 12 hours per day. The part-time rigid bracing is they're going to wear it basically when they're outside of school, as well as in bed. So it's basically like touring like ADLs minus school. Full-time rigid bracing, you're basically going to wear all the time other than like showering and exercise. And then soft bracing is something that's recommended. The hardest part with bracing, compliance, is usually awful, to be honest. And there's a lot of reasons for that. Like, thankfully, we're past the days where like people have these braces that are like monstrosities. So a lot of kids that I treat who have braces, like, unless I'm really looking, I can't even tell they have the brace on because they're very specially molded to them. But that being said, school's hard enough as is, and a lot of kids don't want to deal with having something like a brace like on their body. So there's understandably challenges with the compliance with things like that. So they used to never recommend like the part-time like outside of school, but they realized that people were not wearing it at all. So they kind of changed recommendations to be like, okay, well maybe when you're just not in school, wear it. And it's following the some may be better than none mentality. Research is still out on that. But when you do have somebody with a brace, I typically just try to do my best to kind of drive how important it is to help prevent the progression of their condition. And And I usually encourage them to get a really cool pattern or something on their brace. So yeah, it is good for you guys, I would say. If I think you do, to have somebody like a contact who does bracing for this condition, because that's obviously not something we're doing, that's not something we're fitting, that's not something at all. But to have an orthotist or someone like that just to get those braces attached. And then the recommendations for the following slide, when you see the min to max, this is basically the order of operations. So based on the recommendations, the like minimum recommendation is technically none, but if you see anything, it's the observe every 36 months, goes down to more frequent observations, and that means an office visit with their provider. And then the first thing you would do is scoliosis specific exercise, and then from there you're going into the different variations of bracing, and then unfortunately if you reach the very bottom, that's when you're reaching surgery. So let's take another look at this slide. If you guys can't see it, come up a little bit. It's important to take a look at this. Because this is something that we actually provide to, like I provided to some of our scoliosis physician providers to help them kind of guide decision making as well. But you'll see, so if you get a referral for a 12-year-old with scoliosis, on the referral and on the radiology report, it might say that they have a curvature of 25 degrees in their thoracic spine. They are Risser level 2. So I'll look at the moderate because it's 25 degrees. They're an adolescent and it's Risser 2, so I'll drop down. I realize you can't see my mouse again. But it basically lands on the minimum recommendation of PSSE, which is physiotherapy specific scoliosis exercise, and the maximum recommendation of full-time rigid bracing. So the recommendations are anything in between PSSE and full-time rigid bracing. But you'll notice the recommendation is not surgery. So it's nice to have patients, it's nice to have patients and be like, you are not in the surgical range. Like there's nothing, like I wouldn't even worry about that. Like these are recommendations for you, do these, and it's very likely that you're gonna continue to get better. And your recommendations may change. So if I see somebody and they're 10 and their recommendation might be in the low Cobb angle and like Risser 1, but then I see them 3 years later and it's moderate in Risser 4, the recommendations change over time. So it is a dynamic scale. But this is a really nice thing to do, or a really nice thing to utilize, so you just know you're in the right range for that. So I think this is super useful, again, especially from like if you're doing a direct access referral and you're just unsure, like, if they're 40-something degrees, like what does that mean? It doesn't mean they necessarily need surgery, but it does mean that if it was never brought up, it's a conversation that maybe should be had. Not you telling them, it may be like talking to the provider, like their physician provider or something like that. Okay. Does that all make sense? Any questions on that? And again, this isn't like the only one, this is the most common one though. So this is based off of the SOSOR guidelines. Cool. All right, let's get into the stuff that we're actually really good at. So let's go into physiotherapeutic scoliosis specific exercises. We talked about what general conservative care should be working on. For our scoliosis specific exercises, there are 4 recommendations, again, that SOSOR provides. It's basically this, quote, auto-correction in 3D. So making the patient move in certain ways or set themselves up in certain ways so that they can best correct their posture, which is incredibly vague and qualitative. But that's the hard part of this condition. But you are trying to set the patient up so that things that they are doing or ways that they are positioning themselves are getting them set up in the most stable position. Training in ADLs, this is our bread and butter. Doesn't matter which condition they have. This is very straightforward. Make sure that they can do all the things they need to be able to do, lift, bend, twist, whatever. Stabilizing their correct posture, get stronger, working on just building up muscles around the area. And we'll talk about some considerations for that. And then patient education. So the same way we talked about with our chronic pain, patient education goes a very long way. You want to make sure that patients leave feeling motivated and excited to actually address their condition versus leaving thinking like, oh my God, I need to get a brace, I need to get surgery, I need to do basically the same anxieties that I'm sure any of us would have if you're given a diagnosis. So just make sure they have a good understanding of what's going on. You have a lot of evidence to back it, and then talk it from there. So that being said, just as a quick, I'm saying this to make you guys feel better because it made me feel better after I had initial dread. So this is just how levels of evidence are graded. Typically, 1 means that there is a pretty high level of evidence using a really good randomized control group or meta-analysis. 5 would be studies without any control groups. It's usually an expert opinion, and then basically, so 1 is the highest grade of evidence, 5 is lower, and then grades recommendation, A through E. A is strong evidence for efficacy, B is strong moderate evidence, and then it just gets less recommended from there. For most physical therapy interventions, I think we know this, we operate in the yellow light zone, where it's a lot of B's and C's. We want to avoid doing anything E's that are proven to be harmful, but for the most part, there's very few things that are it's just the way research works. There's very few things that are yes, you 100% should do X, Y, Z. So this is an overview of the recommendations of scoliosis-specific exercise to prevent scoliosis progressions during growth. There are no A's anywhere, okay? There's a lot of B's, there's a lot of C's, and the levels of evidence are not great. It's kind of all over the place. Initially, I looked at this and it was okay, so there's no evidence that what we do works, but I've realized over time that is not really the case. It just shows the vast the variance in care provided, just like any other physical therapy-based condition. And the fact that there are no red lights and it's all yellow lights tells me that I am good to move forward. I just need to consistently reevaluate my methods, make sure we're moving in the right direction, and again, just make sure we're moving in the direction that we need to. So this is more so saying we as a profession, we as global providers are not great as of yet in treating this condition, but we do have evidence that it's working. We just haven't really nailed down what exactly to do yet. So, and then likewise, this is more so the last one was to prevent progression of scoliosis. The next one is basically seeing how much more effective the addition of scoliosis-specific exercise is to bracing versus bracing alone. And again, it's similar where there's no A's, but it's a lot of it might help, but there's no it won't help. It's a lot of just in between type thing. So when we talk about recommendations for treatment, I'm going to give you my recommendations. You guys might find things that work better for you. Please do them. We obviously all treat very differently. It's just important that you just are constantly reevaluating, reassessing, making sure you're moving in the right direction for the individual. So, that being said, what can we do? When you are looking at a radiologic evaluation, these are some big terms that you'll see. We already talked about most of them. The only ones we haven't really talked about, the central sacral line, you will see it drawn on, and it's super helpful when they actually do put it on the x-ray. It basically just goes down all the way up, and it shows you generally the frontal plane balance of the spine. The apex of the curve is what we talked about before. It's usually the most laterally positioned or the most severely rotated of the vertebrae. The upper end plate of the vertebrae and the lower end plate of the vertebrae are going to be used for the Cobb angle. Cobb angle is the angle of the scoliosis. You'll see different degrees of vertebral rotation, different scales that they might use. And then you will see the Risser score that we talked about very infrequently. There's one radiology report I received that did say this. There's a Sanders scale, and I'm not too familiar with it, but it uses the hands, fingers, and wrist, specifically of the left hand. I don't know why. But it looks at those, and basically it's a similar scale, and it looks at how the bones develop over time. I'm including that because it is something you may see, but I'm not too familiar with it. And again, it usually in this area, at least, that's not something that's very frequently looked at. And then you might see any type of other they might mention the pelvic obliquity. They might say that there's like a pelvic rise by 3 centimeters, 3 millimeters on one side, or any potential like listhesis coming in. So this is where we're actually going to finally get into our stuff. Okay, so for clinical evaluations, first thing, there's a lot of different scoliosis specific functional outcomes to utilize. The two that I think are most valuable as a clinician, things you actually get things from, are the SRS 22. So the Scoliosis Research Society published a outcome measure with 22 questions. They're all answered on a 1 to 5 scale. Some of them look at pain, some look at function, some look at self-image, some look at mental health, and then there's satisfaction, dissatisfaction with the management of their condition so far. You can use it for individuals aged 10 and up. I do have I'm going to pull it up real quick. Okay, well I have it up on my computer. Hold on, let me kill this for a second. And then, yeah. So I'm not going to go through all of them right now. It's a pretty standard outcome measure, but like I said, it does use the 5 of those different scales. Looking at pain, basically telling you how they feel from like a mental standpoint about their condition. There's aesthetic questions, which I think are really funny. How do you look in clothes is like one of the questions. So like, I always, when I give this to people, every single time am like, you're going to get a questionnaire and ask you a lot of different aspects of scoliosis. Some of them are going to be very like relevant for you. Some of them you might be like, why am I answering this? I promise you there's a point, like, do your best to answer. And if you feel uncomfortable with anything, just let me know. But there's never been an issue because I think most people understand when they're filling it out. So that's just something that we kind of utilize. And then scoring, I usually just use the ortho kit and I just type in like whatever there's like an ortho kit online where you can use with all functional outcomes. I usually just type it in, but then it gives you a 1 to 5 scale for each of those subscales. So, oh God. I have turned into that guy I hate, where I have to like, how do I use this thing? So it gives you a 1 to 5 scale with each of those subscales on there. And then it just gives you things that you know you want to work on over time. So, because you might have individuals, and this happens a lot, you might have individuals who are referred with absolutely no pain at all. And you're like, what are we working on? Like, you have no pain, what are we working on? And it gives you an idea. So for some people, you might realize that they have poor self-image and that their function feels relatively limited. And you're like, all right, let's just work purely on functional mobility. Let's purely work on resistance training or whatever it may be. Whereas other individuals are just pure pain-driven. So,
is that something that you would look at on like eval and then every subsequent re-eval, or like what's the frequency that you're doing that?
Usually depends on the frequency that I'm seeing the patient. Usually I always give it on eval. I try not to set I usually give it on reevaluation. I almost always give it on reevaluation. I don't when like I feel like there hasn't been a huge change. I don't want to like exactly. That's exactly what I'm trying to say. Like if I don't think there's been a huge change, or I will give it to them if I know there hasn't been a huge change and they're not doing anything. Right. So there's a little bit of a play there. But like I'm generally not gonna like if an 11-year-old's doing everything they can, but I'm like there's not a huge change, I'm not gonna be like, look at how much there's no difference. But I usually do give it every reevaluation. And it is validated for ages 10 and up. So you will get referral for juvenile scoliosis. A lot of the questions again are kind of like strange for like younger kids especially, but the information is not validated for below 10. And then for a more, so the SRS is what they fill out, you give that to them. The READCO is a posture score sheet. It looks at sagittal and frontal plane alignment. This is filled out by the provider. So this is actually what you're gonna do really quick. This, for me, takes the place of like when you're filling in the posture section and you're like, patient has forward head, rounded shoulders, depressed. You can do this instead, and it's a really, really quick checkbox to do. It's highly subjective, to be fair. I shouldn't say that. It's not highly. It's highly based upon the clinician performing it. But this is how it works. It looks at the head, shoulders, hips, spine, and ankle alignment, and it does it both in the frontal and sagittal plane. This is one I think would be really good to just take like a few minutes to do on each other, just to get an idea of how you can run through it. And at this point, I just like, you can kind of fly through, and you will find that like, if one is off, just like that first picture I showed you, there's almost always going to be another one that's off. So don't be like, oh my God, this guy is everything mildly. That's normal, okay? If the pictures look like they're from 1980, I think it's because they're from 1974. So there hasn't been many updates from there. But this is a nice way, instead of me just going through it like a very, very descriptive like stream of consciousness, like this is what their posture looks like, I'm able to fill this out. I'm able to give them a score, and I put this in their chart, and then we have a good idea of what it looks like. All right? When you are doing posture assessments, you typically want to be like as unimpeded as possible. So like, again, depends on your comfort level, depends on the patient, depends on, so like you might have a person who, just like their low back evals, you might have a person come in and like whip their shirt off. You just want to make sure you're not doing it through like a hoodie or anything like that. So in all the European studies, everyone's always shirtless. Everyone. The American ones, everyone has like bodysuits on. So it's pretty funny. So yeah, this is the READCO posture assessment. Can you guys, I should have sent this to you beforehand. You can definitely Google and pull it up.
Just email it to Emily.
Yeah. Can you guys try to find it on your computers? Just spend a few minutes just doing this real quick.
Keep print from your computer. Keep print from your computer.
Yeah.
Again, these are things I was going to send you guys, but I probably should have sent you before.
Do I just Google it, Chris?
That's probably the best way to do it.
Yeah.
That's the READCO. Oh, and this is something I do on the first day, and I usually do on the last day as well, because you should notice some improvements with this. Have you guys been able to find it or haven't? Yeah.
You print from there.
You guys able to find it?
I do.
Nobody.
Oh my God. And I was like, oh,
Thank you.
They're like, no, man.
Yeah. So just for the scoring part, just make sure you're looking at like each, like whatever it's asking for. So if you're looking at head and you notice their shoulder like this, don't be like, oh, their head's off. No, their shoulder's off. Just try to check that off.